How's it
Hey
going, man?
man, how are you?
Good, man. How are you? Thanks for having me.
Yeah, no worries at all. I'm quite excited with this one. I've been poring over the material, as it were, from that you sent me the other day, and it looks really interesting. So I'm really happy to have you on.
Yeah.
Um, yeah, how are things where you are?
Things are good, man. I thanks for staying late and doing this. I had to go to the office today. We're still seeing emergencies. We're going about 3 days a week or so, and as you know, endo is mostly emergencies. So we try to compile them and reduce hours as much as we can. But
Yeah,
um, just got back, changed, and ready for this. I'm excited about it.
yeah, you've done quite a few actually. You've had all the names within Endo on your own channel recently. So I'm
Yeah,
here
we're
with the
doing.
pro.
Yeah, I mean, we're doing this series, which now it's like going to the 20th episode.
Mm,
It's been a lot of fun, you know. It's been a lot of good feedback. You know, a lot of people seems to be like getting benefit from this topical endo kind of chat. You know, just getting
yeah.
some pro tips like here and there. You know, like people are like applying them. Some things people haven't even heard of. So I think it's been great.
Yeah, I think that's certainly what we found. You dropped in when I was with Karina the other day,
Yeah, yeah,
um, and we had so many questions. I
yeah,
think more questions sometimes than any other discipline that we cover.
yeah,
I think implantology also gets quite a lot of questions as well, but the endodontics, it's like it's such a dark art for some guys out there, and they struggle so much.
yeah.
When we have really useful guests like yourself, Karina, we also had Brett and Michael on a couple of weeks back as well. We get such a deluge of questions, so I'm kind of keen to keep on going and um, expand the horizons of the people who maybe don't know as much about what's possible with endodontics.
Yeah.
Um,
I mean, as you know, any field in dentistry that's outside of the comfort zone when you were trained as a student gets a lot of attraction. You know, like I mean, I was trained in different countries, and it was pretty similar in the Middle East than here. People don't
yeah,
graduate with so much exposure to endodontics, and as you know, on the sim lab versus what you do in real life, totally two different procedures. Everything is nice and dandy, and but when it gets to real life, it gets a little bit tricky. So I think it gets attraction because people want to learn more about it and expand their horizon and practice.
yeah, for sure. It's like night and day, kind of, the standard general dental practice of endo versus the
Yeah.
specialist level practice of endo. And I think that's if you've spoken to the other guys, they'll have told you that I'm crazy about endo, but I'm very early in the stage. I've just qualified, so I'm 18 months out of university.
Oh, that's
Um,
awesome.
I need to go back and then do my endo. So
Yeah. Are
um,
you gonna go to postgrad?
yeah, I'm like 90% certain. COVID's thrown a bit of a spanner in the works, but that's the plan.
That's
Um,
awesome, man. That's awesome. You should.
which is it might for you guys watching might be a little indication why there's so many endo guys coming on.
Well, that's why when you asked me, and it's funny that you mentioned that, you know, when Karina. By the way, Karina has her own spell, so it's probably because of Karina you got a lot of attraction and questions. She's just awesome. She's a phenomenal person. I love talking to her. She's
Mm,
great, and but yeah, I figured to talk um, a little bit outside the box of your traditional endodontics, just to kind of shed some light about what other possibilities the field has. And this is such a trophy case that I really like because it has diagnostic dilemma, it has
mm,
surgical component, it has endo component, it has a restorative component to it, and a very nice progression of a favorable outcome. So
yeah.
I think it can raise a lot of questions. And like I said, man, we can go through this case. I'm more than happy to answer any questions in the comments, or if you have anything further after that,
Yeah, for
we're
sure.
all
So,
game.
guys, get your comments in down below. But on your screens, there's a little aeroplane, paper aeroplane button. Hit that button and invite some of your friends who are interested in endodontics who might not know this is going on. Hit 5 or 6 people, man. Let's dive in though. Abs, what exactly is going on in this case? Ahmed even.
Uh, yeah, yeah. So let me just like, I'm gonna walk you through the case. I'm glad you figured out the projection thing. It's pretty helpful. So what you're looking at right now is the periapical radiograph of a lower right 6, 7, and 8, which is mandibular second molar and mandibular third molar.
Yeah.
So this is a 26-year-old female that showed up to the emergency room, and which we have an emergency clinic while I was a resident. And I came down to take a look at it, and she was in a lot of throbbing pain, very sensitive to temperature. It was a very exaggerated response and lingering upon cold testing on the mandibular second molar. So we call it tooth number 31, which is a lower right 7. Okay.
Yeah.
So if you can like just focus on that PA image a little bit, clinically, I can see a lingual crack. Okay. And if you focus on the coronal portion of that, you can see a little vertical shadow, which was exactly where that crack is. There was a deep isolated 9mm probing where that crack was, okay? We're already thinking that this is a crack that's extending down the roots, so we're not really like happy about that. So I wanted to take further imaging as far as CBCT or anything like that, just to kind of like show if there's a pattern of bone loss alongside the root, which can be an indication that this crack is extending down the roots. But since it's an emergency setting, limited time and all of that, and the patient was in so much pain, I decided to open the tooth, do a pulpectomy to remove the inflamed pulp just to take care of patient symptoms. And then at the same time, under the microscope, we can evaluate how deep that crack is extending. Which in this scenario, after we opened the tooth, we got the patient numb. If you can flip to the next picture, you're going to see the crack. Okay, so it's very classic. You remove the occlusal restoration, as you can see on the top left picture. You can see the beginning of the crack just in the dentin. And those are just 3 different magnifications under the microscope, showing that the crack is extending all the way down the mesial lingual canal. Unfortunately, sometimes when you magnify to the highest level on microscope, you lose resolution. So the resolution under the microscope is way more clearer than when you take a photo. And that's basically, I don't know if you can see it, but it's extending deep down the canal. So I finished pulpectomy just to get the patient out of pain, but I told the patient, this is a case that's probably going to end up with extraction because it doesn't have a really good prognosis. Okay.
Yeah, for sure.
Now, this is very, like unfortunate, and it seems like a sad ending to the patient. But then just looking at the PA, I saw that the anatomy of both the wisdom tooth and the second molar are very similar, okay? Which gives us the idea that's outside the box of thinking of using that wisdom tooth to replace that second molar in a procedure called an autotransplantation, okay? So we take the tooth out and then you replace it with the wisdom tooth after extraction. You splint it, and then it should have a good outcome. But then before we jumped into anything, the patient was confused. She works in a floral shop. She's a very, she didn't have aggressive dentistry other than long-term orthodontics, which caused that malocclusion function that she has, and she ended up cracking this tooth. So she was like, what are you talking about? What do you mean taking tooth and put it in? Like, it's a very foreign concept to the patient. So I was like, let me take a 3D scan, and then we're gonna sit down and just basically go over it with her, just so she can have the option. Because the second option is to replace that tooth number 31, which is the second molar, and then obviously place an implant. Okay. Financial was an issue, obviously, like implants are more expensive in this scenario. And really, like this is something that she can try, and if it doesn't work out, an implant is always a possibility in the future. Okay. So what you're looking at is 4 different slices of the CBCT. Okay. I know you're trying to zoom in, but
I'm just zooming in on my face, guys.
Yeah. You can't do that. It will be nice, but I tried to make it to a point where you can actually see it.
I think you can, but I was just trying to see the extra.
So I'm gonna jump in right to the top right picture where I have an arrow saying bone defect. That's an axial slice of the tooth, showing exactly where that crack is. As you can see the radiolucency around it, that's where the probing depth is. And if you look at the bottom left picture, also marked as bone defect, this is basically where the crack is extending down, okay?
Yeah.
And that's just a confirmation, more of a confirmation that where this crack is, you know, like extending. But then look at the axial slice where I marked with blue on the top left, okay? You can see that even more of a better candidate for autotransplantation is that the wisdom tooth is slightly smaller, okay? So it's smaller that would even fit in that. So you don't need the socket to be modified where the second molar is so the wisdom can come in and fit. Sometimes you need to do those. But in this scenario, and look at the bottom right, like they're so similar in anatomy that this will make it such a favorable donor to that site, okay? So basically the arrow is an indication that where this tooth is gonna be heading. Patient was game.
Yeah, so you can see this, the shape.
Yeah, exactly. But CBCT, you can get on the slices and you can measure mesiodistally and buccolingually. You know exactly. And you can create a 3D volume rendering of the tooth.
Yeah.
So you know exactly if it's going to fit or not. And some people go to the extent of making a plastic model from the 3D rendering. And when you take the hopeless tooth, you can fit your model to make sure that it doesn't need any adjustment in the sockets. Okay, which I didn't do. It just took time and money, and it was in residency. So we just proposed it to the patient, and the patient agreed that she wanted to proceed with that. Always patients expectation is key. Yeah.
What about occlusal anatomy and the bite? Is that something that you're able to assess in with this imagery?
Not with CBCT, but this is a very important question because you need to make sure that there's no heavy occlusion. The tooth needs to be functional, okay, as it's sitting in the donor sitting in the socket before it stabilizes. But you need to modify the inclusion, which we're going to be touching base on as we further go in the case.
Yeah. So I head over to the next slide.
Yeah. So you can hit the next one. So this is the day of the procedure. Okay. As you can see on the top picture, you can see the first mandibular molar with the amalgam, and then the second mandibular molar, which is the cracked tooth, and then the wisdom tooth as the third mandibular molar. So we ended up extracting the tooth number 31 first, which is the second molar. And then, and the bottom left picture is after we extracted the wisdom tooth and placed it immediately in the socket of the second molar. And one key information when you're doing those cases, the success rate of those procedures, whether it's autotransplantation or intentional replantation, depends on two factors, majorly. Atraumatic extraction, meaning no elevators and no manipulation of the PDL ligaments as minimum as you can. I know when you're extracting the tooth, you're severing the PDL ligaments, okay?
Yeah.
But doing further elevation will definitely crush the PDL cell to the sides, and you will have less chance of attachments, okay? So this was done with forceps only. It takes time. It's a lot of, it takes more time and it needs more patience. But you got to do it this way to have further success in your procedure, okay?
Yeah, you're lucky with the roots as well here in that it's a conical shape. Anything with a kink on the end, you're kind of stuck a little bit there.
100%. And that's why this was like the planning was key, is just to kind of look at it from every perspective to make sure it has a predictable outcome, okay? Mm-hmm. So then the second thing that, you know, dictates success rate is the time outside the oral cavity, because some procedures you might require to do the endo prior, and then you take it out, and sometimes you do the apical outside, okay, which is like an intentional replantation. So the extra oral time, how long the tooth is sitting outside of the oral cavity, also dictates. The longer it is, the lower the outcome. So the key, and then I'm gonna show some good resource that everybody can look at, is about 15 minutes, 10 to 15 minutes. Anything longer than that, it will be a lower outcome, okay? Yeah. Obviously, in this case, we didn't do the endo prior because it was the wisdom tooth, accessibility was difficult, okay? So we ended up doing it after. I'm gonna just go over the splint image, which is the bottom right. This is a glass fiber splint with composites. And if you look between the picture to the left and that picture, you can see that I adjusted the occlusion and the cusps were flattened. Okay.
Pre-adjusted.
Absolutely. So you check the occlusion and you keep adjusting. You want it to be in touch with the opposing tooth, but not heavy contact. You just want it to be in like a very slight functional occlusion. That's all. So you basically keep adjusting it until you're there. And we are already knowing that this is going to be getting a full coverage crown because the patient is a clincher, has a history of cracking teeth. We wanted something to protect it. So I wasn't worried about taking too much tooth structure if it's required.
We've got 2 questions there.
Yeah.
Is diabetes a something that you're going to consider? Would you consider doing that on a diabetic patient? I think that's the question Sergio is asking.
Yeah. So as far as diabetes, we all know from literature, diabetic patients have a lower healing rate, but that doesn't mean it's impossible. Okay. Yeah. So if you're doing an extraction, if you have a periapical periodontitis that requires some healing, it will heal. It just takes longer. Okay. So I wouldn't be too concerned about this as far as if I have a diabetic patient or not.
Yeah. And then sweet tooth dentist, I think that's what it says, or the dentist. Do you have to place the tooth in a solution while it's outside the mouth, or do you go straight away?
Yeah. So like I said, if I'm doing any procedure, like let's say I'm doing the endo outside, or I'm doing the retro prep or resectioning the root end, which is in case of intentional replantation, then yes. In this scenario, I just took it out and put it right in. Okay. So I don't need any solution because I don't have a waiting time extraorally. But if you're doing an intentional replantation and you need time to do something outside the mouth, Hank's Balanced Salt Solution, which is the same kit as Save-A-Tooth. Do you guys have Save-A-Tooth in the UK?
I'm sure we can get hold of similar things, whether it's called Save-A-Tooth or not. It may just be down to branding. So
if you're buying it from a dental company, it comes in a bottle and it's called Hank's Balanced Salt Solution. So the key to this, it's a neutral isotonic solution. So you need something that's not high pH or low pH. You need something neutral to preserve the PDL cells. It's basically the best solution to keep any avulsed tooth. Like if you have a trauma case, and the best solution to keep it in is the Hank's Balanced Salt Solution. And they sell it on Amazon. It's like a kit. It's like a bottle.
Karina says we have Hanks.
Yeah. So if you don't want to get it from a dental company, you can buy it off of Amazon. It's like $10-15.
Yeah, and Karina also says she's used Copac once and stitches for a similar case.
Yeah. So if I'm doing in this case, you have 2 types of stabilization you can do. In this scenario, I decided to go with the glass fiber splint to just basically bond it to the teeth in front of it. The other thing you can do is you can do an 8-figure suture on top of the tooth to stabilize it, okay? I usually do those in mandibular second molars intentional replantation cases. And in this scenario, I had an assistant. I was getting good isolation. I was able to do like a nicely bonded splint, so I just went with that option. But you can definitely do other stabilizations methods.
Yeah, sure. Let's move to the next slide. I think we ran out of questions on that slide, which is great. Awesome. So this is just after you've planted it.
Correct. And by the way, you can stop me at any time if you want to go over questions that's relevant to whatever I'm talking about.
Sure, we'll do,
just stop me, okay? So this is a confirmation x-ray after we splinted the teeth. And as you can see, the extraction site of the wisdom tooth, and you can see where that donor tooth is fitting into the socket. And we know from the CBCT, you're going to have space around it because we know it's smaller, okay? So that's just basically a confirmation. And at this method, and at this time, we are bringing the patient back within 1 week to start the endo, because you treat this just like the guidelines you have in trauma. If you this is basically an avulsed tooth with a very favorable environment because it's in blood, it's in the patient's mouth. It's not sitting dry or in milk or whatever. But the guidelines is to start the root canal treatment within 1 week, okay? Sure. Also, the guideline for autotransplantation is to do this in 2 steps to maximize the calcium hydroxide effect on the healing process of this donor tooth. It's debatable, but that's what the god of autotransplantation guy recommends. His name is Soki Boshi. I brought the book with me. This is called Autotransplantation of Teeth. So he has so many published cases with phenomenal follow-ups, all different types, all different cases, all of his own. And he has like 5, 8, 10, 20-year follow-ups, which is amazing. If anyone is interested in this topic, I can send you a picture later. You can post
send
it.
me the picture because that's back to front.
Back to front. Yeah, I will send it to you and we can share it with everybody.
Awesome. Raina's asking, she was on Saturday, 5 tips for endo. Her topic was, she's asking, is it better for a surgeon to do the extraction and us do the endo if we're working in teams of specialists?
100%. Do whatever you're comfortable with to assure you have an atraumatic extraction. Okay.
Yeah.
I was a general dentist for a while. I'm very comfortable with extraction, so I did the procedure myself. But you can definitely bring someone along. As a matter of fact, I have a periodontist that I work with, and recently, about like 6 months ago, I did an intentional replantation case that I thought is going to be a little bit tricky to take it with forceps only, and we worked on it together. He did the extraction, I did the apical outside, and we placed the tooth back. I think that was a better experience for the patient. So do whatever you're comfortable with to achieve this result.
Yeah, it saves your wrists and arm muscles as well for the next half.
Absolutely.
Let's have a look at the extracted tooth because that was really interesting. We always see, you know, an access cavity, and then sometimes we see the crack internally, but you've actually stained it here. So you can see the extent of that crack. And if we try to do endo there, you know that's going to fail because there's no way we can run that out.
Yeah, and that's probably for some people who are watching the picture that I showed through the microscope. They're like, well, yeah, I see the crack, but it's not really down the canal. I can't see it down the canal. But like I said, the resolution can be a little bit tricky. But now this is just a confirmation of what I was showing internal inside the tooth. You can see exactly, and this staining, it's called methylene blue. I use it for surgeries to stain if I'm suspecting a crack. I usually stain the root end when I'm doing surgery to assure there is PDL through and through. That means I have a clean resection. If you don't have methylene blue and you don't want to buy it, that's fine. You can use caries detector. It works the same thing. Okay.
You'll see the line. It'll get into the little area and you'll be able to see.
Exactly.
2 questions. How do we bill for this? If already covered, don't worry. You can ask it later.
No, that's fine. Is this Neil? Oh yeah, this is
Access
Neil.
Endo.
I thought I saw that. Yeah. What's up, Neil? So there is actually a code for autotransplantation. Okay.
This is the American guys.
There is a code for autotransplantation. So let me tell you exactly how this was billed, because in residency we still bill. Okay. So this technically you charge an autotransplantation code. You charge 1 simple extraction. Okay. You can charge for 2 technically, but I didn't. We just wanted to help out the patient. Okay.
Yeah.
So you charge autotransplantation code, simple extraction code, and also a root canal treatment and resin filling.
Awesome. And then we've got Dr. Shara Smile. Did you do an apico on this one? Because she's not sure about that. I don't think you did you?
I didn't do. No. We didn't do an apico on this one. If this was a previously treated tooth, like I said, if I'm doing an intentional replantation, we will extract the tooth, do the apico outside, and place it back. Yeah.
Okay. Awesome. So that's the crack that you can see there, guys. Hopefully you've had enough of looking at the crack now, because I'm going to move on to the endo.
Yeah. So like I said, I did this in 2 visits. So I brought the patient back in 1 week. Patient was asymptomatic. I can still see soft tissue is not completely healed yet. Because it's a glass fiber splint, you can't really detect mobility, but you can kind of tell it was still a little bit mobile. Okay.
Yeah.
So that's why I'm having a splint, because I want to stabilize my clamp while I'm doing the endo. So I opened the tooth. I cleaned and shaped. I placed calcium hydroxide, brought the patient back after 2 to 3 weeks. Soft tissues healed very nicely. Patient is asymptomatic. And then I went ahead and obturated the case, and I placed a resin bonded filling, as you can see in the x-ray. And this is the immediate post-op. You can still see the space. Obviously, this has only been like 3 to 4 weeks.
Yeah.
So obviously, like, there's no bone healing yet. Okay.
On the
So
clamping issue,
yeah.
are you somebody who clamps the one tooth, or do you go with quadrant isolation so you can get more access?
So you got to put in mind, this is the last tooth now. Okay. So you can't access anything. You can't clamp anything behind it. Okay.
No.
So in this scenario, because I splinted the 2 teeth in front of it, it was quadrant isolation.
Yeah. Because
and I use we call it like a opal dam or oroseal, which is something that you put alongside the teeth and you can cure it. There's 2 types. There's a putty type, and there is a one that's like basically a flowable that you use for whitening to protect the gums. It's the same thing, just to seal your dam when you're doing a split dam.
Yeah, because I was thinking you could have used something like the haloclamor or something like that if you had, that kind of a clamp, and that would take the onus away from holding onto that tooth. But
oh yeah,
either way kind of works. The results are there to see for itself.
Yeah.
Is there any benefit in doing a root canal outside the mouth before you place the tooth in, or does it really matter in the long term kind of?
So that's why you have to decide. You have to decide how much time is it going to take you to do it outside the mouth. Okay. So for me, I would rather keep the extra oral time to a minimum, which in this case is like less than a minute.
Yeah.
Versus trying to access, do the endo, and like probably going to run out of time. You don't know what happens. Okay. But it's definitely doable. You can definitely do that. Okay. And then you place it back and then you're done. You just splint it for 3 to 4 weeks and then you're done after that.
As we say that, Neil's answered in the comments as well. So he's on the same page. He's on the same page. Let's have a look at the follow-up. So this is 6 months later.
Yeah, so this is 6 months. You can see apically there's very nice progression of healing. Okay, you can see the socket of the wisdom tooth has started to filling in with bone, but you can still see a shadow vertically on the mesial side that still like did not heal completely. Okay, so this is the 6 month follow-up, and I think I also have a soft tissue picture. You can see how that soft tissue is beautiful, like no splint. It's very nice. It's healed. It's healthy. So I was very happy at that time. Obviously, no mobility. By the way, I saw this patient on after 1 month, 3 months, 6 months, and a year. So it's a close follow-up. I want to make sure, first of all, mobility stabilizes, and also soft tissue is healed completely.
Just going back a slide, or to whichever one you want to look at. When you've obturated, what are you sealing your canals with? What are you placing the core in this case as? Because obviously you're doing a lot of follow-up. Is there a thought in your mind, I might have to go back in if something's not quite gone to plan? Or so are you planning ahead for that? Some people might not place, for example, a composite to seal the canals because it's very difficult to remove and find your GP again. What's your thought process in that scenario?
So you got to put in mind, this is a virgin tooth. Okay. So basically you have no bacteria inside of it. This is not a necrotic tooth. There is no source of bacteria to invade it. So technically you're basically dealing with a vital case, which has a very high success rate. Okay. So you are removing all the variable because you know what you're dealing with is a totally healthy tooth. Okay.
Yeah.
So I am not worried about removing composite. I know it can be a pain. All right. But with magnification and everything, if this tooth needs to be retreated, easy. Okay. It's not a problem. I'm not too concerned about it, but I am concerned about leaving it as something temporary. I don't want that. I don't want any coronal leakage. I want to seal it.
I'm more looking at the peri radicular sort of area, just as you're dropping into the canals. Some people do like a sandwich technique with a GIC or something along those lines to seal the canals and then fill up with composite on top. I don't really see the point in that, but I thought I'd ask you anyway. I
mean, if you talk to any really endodontist or I'm not sure where this GI layer is coming from. I mean, bond like absolutely directly to the gutta percha points. You need to condition the cavity very well. So what I do is I do an alcohol scrub. I do a total etch. I usually clean my sealer very, very well. That if you have seen my cases, I mean, I don't have a drop of sealer anywhere. That gutta percha looks pink.
Yeah.
It looks very, yeah, like very clean. You got to etch it, condition it, bond it properly, and it should be absolutely fine. I understand the GI liner concept if you are temporizing it just to send it back for the restorative dentist, and then they can just keep that GI liner and bond on top of it just to protect the gutta percha. I understand that. But if you're restoring it permanently with a restorative fill, with a restoration that's going to be the permanent filling, I'm just going to bond on top of it immediately.
Yeah, yeah. I think that answers the question really. I thought it's something that there is some sort of debate on for some reason, so I just posed the question to you. Let's move back forward. Haim, I think that's how you're supposed to say him. We would be providing full coverage crown on this one afterwards as well, won't you?
Yeah.
So this is where we are. So that's the 12-month and the crown's gone on.
Yeah, so this is 1 year. This is the 1 year recall. On the 6-month recall, when I saw everything is going well, I went ahead and I was like, let's get this restored with a full coverage crown. Patient went and got a full coverage crown. And now you can see like complete periapical healing, and the patient is completely asymptomatic. She's happy. We checked her occlusion. Everything is in harmony. And I couldn't be more happy with the result. And the patient is very, very happy because she saved a lot of money.
Yeah.
Yeah.
And I think we've got an all 4 there. So this is.
Yeah. So I put this picture together just so people can have like next to each other. They can see the progression of that healing from the very top left picture where you can see the black, like radiolucency around the tooth, up until post-op, and then 6-month and 12-month recall. This is actually approaching 2 year right now, so I should get a 2-year follow-up on it. Once things calm down and patients can come back for non-essential work, maybe we can get a quick radiograph to see how it's doing.
What's the radiopacity near the apex?
That's a sealer extrusion.
Yeah, I wouldn't be too worried about that.
No. Sealer extrusion, if it's not into a vital structure or anatomy, like the inferior alveolar canal, or if it's in the sinus, it doesn't really affect healing. So it doesn't really concern me.
Yeah. Horizon saying that now the 6 looks in trouble. I'm not sure about that, man. I think it'll probably be all right for the moment. It is quite deep, that amalgam though. So
yeah, and given the patient, I mean, we already discussed that because she has those amalgam restorations on her molars, and I told her, I was like, with your history and with the way your occlusion is, I would probably keep an eye on this. And if I already told her to get a full coverage crown or some sort of onlay on this first molar.
Yeah, it's a wide amalgam, which and a buccal extension as well, so it's not particularly clever. Got a couple questions here. If you do you use a resin-based sealer to start with? That's the first part of this question, really, or you?
I'm a big fan of resin-based sealer. There's so many sealers. I don't think any of them really impact healing, or one is better than the other. I like resin-based sealer. I've tried all of them. I just like the way it handles, the way it flows. I'm just more comfortable with it. And it has a really long track record as far as healing. I'm talking 10, 20 years, 30 years, that really it's favorable outcomes, whether the sealer is the dictating factor or not, but it has a long track record in literature, just like ZOE.
Yeah. And then moving on from that into the second part. So this is the actual question. If you use a resin-based sealer, is it safe to do a composite restoration without a GI? And that's from Ellie.
What's the concern? I'm not
particularly sure.
So the ZOE sealer is what there's a concern to them, and I think Karina also talked about it because I think she uses ZOE sealer. So the eugenol can affect the bonding. Okay, not really the resin base because it's resin. So it doesn't have it doesn't have any eugenol in it. And like I said, if you see my cases, I wish I brought a picture showing what the chamber looks like before the resin is bonded. But anyone can go to my page and they can see the cases that I post and the pictures that I put in. there's no sealer. There's just gutta percha on the top of it, because I don't fill the canal with sealer. I backfill with an obtura because I do warm vertical compaction.
Yeah.
So the eugenol has effect on bonding. So you need to clean the cavity very, very well. And honestly, the only concern I have with ZOE, if you're using eugenol-based sealer, is if I'm bonding inside the canal, meaning I'm doing a fiber post. Okay. So now I'm concerned more about that bonding a little bit.
Hopefully you guys can see that. That's one of your premolars. So yeah, you can just see.
Yeah, there are better pictures than this one, but anyway, like I said, you know, I'm not really too concerned about that at all. So yeah.
Oh, it's faffing around on me there. Anyway, yeah, and then we've got another question from Pri. How long do you wait for bone to grow in before deciding if a case is failing? Obviously, this one's gone perfectly and no issues there.
Yeah, well, again, you know, like I consider this a very short-term follow-up. Okay. Literature shows the disease can be estimated as far as healing or healed can take from 1 to 4 years. Okay. But at the 1 year mark, you really have a good idea where this case is heading.
Yeah.
So if it looks like this at the 1 year mark, I'm very happy and I would expect it to keep going this way. Now, if at the 1 year mark, I see that, you know, like you look at the post-op from the post-transplant x-ray and it stays the same, that radiolucency around it, and then it keeps staying the same like that, then, or getting bigger, then that I'm not too happy with that. You know, that means it's not really not attaching, the bone is not filling in. So that's I think this is heading in the right direction. 1 year recall is usually a good indication. But then I try to keep an annual record of like every year after that. Maybe after the second year, I will do a 5 year if things are still going well, and just keeping it like that.
Yeah, I think this case has gone kind of as well as you could really hope.
Yeah, absolutely.
Are you ever worried in these transplantation cases that you suggest this to a patient and then you go ahead and do it, and then it fails and they end up losing the second unit on top of the one that was already unrestorable? And how often does that happen, if at all? Like
I said, you know, like the success rate is so high. It's like 92%. Okay. Yeah. And like I said, the cases that they fail, it's usually long extraoral time or tooth fractures when you're extracting it. Okay. And that's always discussed at the beginning with the patients. Tell them like, this is a possibility, but if it happens, your second option is still there. You know, like your second option is to go on an implant. When you tell the patient, I can attempt something, other than patients who don't have time. Like if they don't have time, then maybe that's an issue. It's like, okay, don't mind this. I'm going to go for like a more, you know, like I just want to come in, get an implant, and I'm done. Even though implants also have follow-ups and you still need to go in for your follow-ups. It doesn't happen overnight. But you have nothing to lose and you're paying less money. It's a less expensive procedure.
Yeah. And do you think that high success rate comes down to correct case selection as opposed to the difficulty of the actual treatment process? Because if you select the wrong case, the likelihood is you're going to have a higher chance of fracture and failure at some point, especially if you're looking at a tooth with some sort of interesting nerve anatomy where you've got an excessive curvature on a root or something. Makes it harder to get out, and then also harder to also treat. Obviously, we see we can treat curves great from a root canal perspective, but there's a much higher frequency or likelihood of that snapping on the way out.
100%. That's why treatment planning those is very, very important. So first of all, the anatomy has to be in your favor. You don't want to like a dilacerated or a curved distal canal and a very long and abrupt curve on the mesials. Those are going to be impossible to take out intact. Okay. Yeah. You got to keep all these things in mind prior to proceeding with those. You got to have the right case. You got to have the right patients. The patient motivation is a huge factor in this. Okay. Yeah. And obviously you as a clinician managing the patient's expectation. I tend to learn because I'm a very like energetic person and I'm always optimistic and get excited about those things. I learned the hard way because I'm so energetic, making the patients feel that this is a slam dunk.
Yeah.
And I've had cases go south. So I learned to always, always lower my patient's expectation. And guess what? If it just surpassed that, I'm a hero.
Awesome.
So you always keep them very low and realistic, in my opinion. Realistic.
Yeah. Tahir, I think we both agree with both your points there. He's saying that eugenol affects the bonding, which is of course what you'd also said. And also the composite would bond directly to the resin-based sealer, so it's an ideal choice there. And Horizon says that these two teeth were basically made to replace each other.
I know, it's amazing.
So yeah, I think this case, hopefully that has been a really interesting kind of look in on some endodontics that people don't normally see, and kind of widen the horizons of some guys out there and just show there's maybe some different options, and if in the right hands, some pretty successful options as well. And Judy Endo's joined us as well. So who's of Endo tonight? I think.
Oh, Judy. A lot of endos are joining. Hey, Judy.
Yeah.
Yeah, I mean, man, I figured, like you asked me, I was like, just why don't you like bring a case and show? And that's why I asked you, I was like, do you want like something a little bit outside the box? I was gonna show you like a nice, like apical surgery or some sort of. I know Karina did a retreatment case that was phenomenal. I wish we can do some sort of like live. It will be very hard to do. Like I have some nice videos that basically shows root canal treatment from start to finish. That will be nice for people to kind of see the steps, and under the microscope, it makes a little bit more of a visual aid. But you can't do that on live. You can't do that on live Instagram. There's no option for it.
Yeah, you can't do it via the native program. I did do something similar with Rizal, actually. I don't know if you caught that one a few weeks ago. He
I don't think so.
It was a posterior composite case he was doing.
Oh, nice.
And he showed us the caries removal, but he just flipped around the camera onto the screen.
Okay.
So that is one way, and then you just mute it so you can talk over it, and you do have control there. So it is doable, but it's not as clean and perfect as kind of this kind of a thing that we've got here.
Yeah. But maybe they'll add that feature. You never know. I mean, the thing is, I have those videos in my library. I can just, and most of them are even posted on my page. If anyone goes to my IGTV, I have so many clinical videos. But anyway, what I'm trying to say is like, it'll be nice to go over it live as we're discussing it right now. Just because, I can tell you like what alternatives are there. We can answer questions, all those things. It'll be nice.
You definitely get a different understanding from hearing the person who's done that treatment. When you've got almost like the director's cut commentary.
Absolutely.
Going in the background, and you can see the visual aids. And it's been really great, really, that so many guys have got on board with this who've, done some really, really interesting treatment. And kind of helping the monotony of everyone sitting at home.
I know.
Not too much.
This is our second job nowadays, is Instagram lives. That's all we're doing.
My first job, almost.
Yeah.
If anyone wants to pay me to do this, I'll happily continue it. No,
I know,
for sure.
It's been awesome.
Got a couple more questions. That's quite a long one from Robert. If you want to quickly read that one.
Says from a business standpoint, this would be consider the ultimate entrepreneurship goal. Clever-minded case selection. Oh, okay, it's just a compliment to the case. I appreciate that. What else?
Right.
Just curious to know, was the patient charged for single extraction and RCT? Yes. So you probably missed what I mentioned earlier. We do have a code in the US for autotransplantation, the procedure itself. But then you have accessory codes, which we charged. I didn't charge for 2 extractions. I charged only for 1, and charged for the root canal treatment.
Yeah. So what made you go into endo?
Pros. I absolutely hated pros, man. No, not really. I mean, I would say that's part of it. Dentures mostly. I really hated dealing with the removable. But you know what, man? It's just unpredictability. I like the unpredictability of endodontics. Every case is different. Anatomy is so different. You don't go to a case and you're like, okay, I know what's going to happen next. It always keeps you on edge, keeps you excited. And it has a surgical component to it, as you can see in this case. And I really like surgery.
Yeah.
So I just figured I did general dentistry for a bit, and it was really tolling on me. I just felt like I'm seeing a lot of patients, your body, all of that. I needed to see focus on one field and, you know, just hopefully do it, you know, like very well. And that's really what made me do it.
Yeah, I think that's probably very similar to what my thoughts are. The pros side of things, I was getting good at dentures at one point,
Yeah.
and then just randomly everything seems to go wrong for some reason. I'm just like, you know what, this is not the one for me. I hate taking impressions, having all this sticky stuff all over my hands.
Yeah.
I much prefer getting the rubber dam on whatever rubber dam work I'm doing.
Oh,
Um,
fantastic.
clean.
No, clean, no leakage, no tongue in the way. Oh my
Yeah,
God. Just like such a peace of mind. And endodontics has a lot of gadgets, man. You'll see. And I love those gadgets, you know, like
I
getting
have a
those
few of them already.
I know, I'm telling you, you know, like you just like you work with so many cool things, and every year there's something new that I don't know, I just get excited about those things. I mean, don't get me wrong, I love the restorative part of endodontics. I love
Yeah.
restorative. And this is probably so I go every year to the endo meeting, which is American Association meeting. But
Oh,
other
nice.
than that, all the CE that I do is focused on bonding, restorative trends, all these things. Like
Mm,
this is really what I pay money for to go learn better. Other than the annual meeting is mainly restorative. But I mean, I'm talking about, you know what I'm talking about. I'm talking about removable dentures and all those kind of things. It's just, yeah. So
yeah, the bonded stuff is much more interesting. I
yeah.
probably looking at Manya's course and stuff, you know, people along those lines.
Oh, he's
Uh,
phenomenal.
I
Pascal
would
Mania.
honestly, if anyone watching is personally in contact with him, please ask him to do a live with me. That's my dream for the
You should
moment.
reach out, man. He will do it. You're talking about Pascal Mania from USC.
Yeah, I'm gonna reach out. I was hoping that someone, you know, that I speak to, or someone that I feature is like got an inside track, and then I use the inside
Just
track and get him on.
just DM, he'll be more than willing to do that, man. I
Yeah,
mean, people are like they're very approachable, and he's a super funny guy too. Like I'm not sure if you've
yeah.
heard him speak before.
I've watched a few of the lives. Yeah,
Oh my God, he's hilarious too, and such a phenomenal clinician too. I mean, he's a really good guy. So just DM him, man. I mean, I'm pretty
yeah.
sure he'll be
I'll
thrilled
get
to
on
do that.
that. I'll let you know how it goes.
Yeah,
Sweet Tooth Dent is asking advice for students. Let's confine the advice to endo,
that's fine.
and see what you kind of say. All right, what would you focus in on, or what do you think about when you're doing an endo? If you're an endo.
Um, a lot of I usually get this question a lot, maybe within the same realm of this, is like, do you think I should be a general dentist or specialize? That's just which is a really good question. I did GPR residency and then I practiced for 2 years, and that's when I realized that I wanted to specialize.
Yeah,
And basically, you need time to practice different procedures, and then you gauge what you like and what you don't like. Because what you think that you have done three of in dental school is pretty cool and exciting might be boring to you when you do it about 20 times a day, you
yeah,
know? So you got to figure out what you like and what you don't like, and then decide whether you want to specialize or not. I know some phenomenal general dentists that are doing amazing work, but it's for me. I'm not that good that I can master everything and be very well at it, and it's very stressful to me.
yeah.
So if general dentistry is for you, you gotta know, like you gotta practice. Do a year, do 2 years, do a general practice residency, just to kind of like see what you like and what you don't like.
Yeah, at the very least, it'll give you some experience and exposure to a lot of work
Yeah.
that you probably need, even if you are going to specialize, just to
Hmm.
get your up to speed. Because when you go through dental school, certainly in the UK,
Mm.
there's a certain number of nurses and a certain number of supervisors,
Yeah.
and there's more students than either of those two. So you are just hanging around a lot of the time, and it can be a very, very relaxed pace.
Yeah.
in the real world, that's not so much the case. You need to speed right up, um,
Like
especially
lock and load.
especially if you are, even if you're a specialist, you can't be spending 6 hours on a single tooth.
Ooh,
No,
no, no.
not a
It's
chance.
it's crazy, man. My first 6 months, I was like going nuts because
Mm,
I worked so I worked with the guy I work with. He's practice limited to endo, and he was my professor in dental school. So I was very lucky with the matchup and everything. And the guy is a beast. Like he's so fast. And I just straight out of residency, I was so slow,
yeah,
right? And so I would see like 3 to 4 cases a day, and I look at his schedule and he's knocking down 8 to 10. And he's
endos.
finishing, yeah, and he's finishing earlier than I am. And I'm like, just going nuts. And it takes practice, takes some time until you build up your pace and everything. And it can get
Mm,
very stressful to you at the beginning, especially because you're feeling you're running behind and all of that. So that's why the real world, like you mentioned, it's a very relaxed setting at the school. You got to
yeah,
go and test it out and see what's in it for you. So
yeah, for sure. Fatih Yunus in the comments. Don't worry, your feature's coming soon. I know I've got it in the DMs. It's ready to go soon. But yeah, I think that's a really key kind of point. But I'll ask you a question, something that I struggle with at the moment.
okay.
Getting into, for example, an MB2. I
Okay.
put up a post the other day, found it perfectly. Thankfully, I've got some magnification, very decent magnification.
Yep.
I can find things now. It's getting down there, especially
Yeah.
on the mandibular and maxillary molars.
Yeah.
You've got that weird kind of kink away from the pulp chamber. How do you negotiate that?
So MB2 classically, the entrance into the orifice is as an abrupt angle and then
Mm,
curves back to the root. Okay. So you have two things. Sometimes this is only restricted at the top where you need to kind of trough with a very small ultrasonic or burr just to open it up a little bit. Then you drop. This is the best case scenario. Your file
yeah,
will drop right after that. But then you remove that dentin shelf and still your file goes in only 5 millimeters in. This is what I called a mid-root abrupt curvature. Those are the worst, okay? So, because what you need to do is you need to pre-curve your file, okay? And I would put a drop of EDTA just because it's lubricant, okay,
right.
instead of sodium hypochlorite. Because sodium hypochlorite, what does it do? It removes only the organic part, okay? The inorganic part is only removed by EDTA. So you'll be packing debris that is not removed and you keep packing it as you go. So the EDTA works a very good lubrication. So once a small file will go in, once you pass that curvature, it's not going to reach the apex.
No.
Just see where it reaches and do pull in and out. Smooth that abrupt curvature. So pull in and out, count to 100. I'm not joking. If you have an 8 file
Okay.
in, do that. Take it out, put a 10, same thing. Put a 15, same thing. Then your not curved file will go in. Okay.
And the file in question, are you using a C plus? Are you using a K file headstrong? What are we using there?
I don't own any K files. I only use C files.
Only C files. Okay.
Yeah. And I don't touch anything bigger than a 10 or 15. So I have, usually my sponge has 6, 8, and 10.
Awesome.
So 6, 8, and 10, and that's it. And I usually like use path files. So after like an 8, if I reach the apex, I'm switching to rotaries right away. But that comes with practice. So, but yeah, that will be my tip. Sometimes, even after I create this, my straight file will not go in. Then you're going to have to pre-bend your rotary file and place it like a small rotary file and place it by hand. And then hook up your handpiece to it and then hit the pedal. And that way it will just grind that abrupt curvature
Right. Okay.
straight enough for you. It's like one of those things, sometimes you got to just like tackle it so many different ways. But I'm not going to lie to you. Did I get down every single MB2 that I've treated? Nope.
Yeah.
There are ones I just couldn't. And we talked, Karina and I, about this when we did Endo Vibes, the instrumentation episode. If you guys want to watch it, it's still there. We
I have
talked
seen
about how,
those.
yeah, so we talked classically MB1, MB2, they reach like this. This is easier when they meet, but
Yeah.
sometimes they meet like this. So this, your file will get stuck here and doesn't go anywhere because that becomes an abrupt curvature to go back. So here's a little trick to know if they join or not. You place your file in the patent MB1. MB1, you place a hand file. You check with the apex locator, you make sure that you're beyond the apex, gives you that beep on the apex locator. And then make sure that that file is beyond the apex so you know that it's reading outside. And then you place the file to where it join on the MB2 and then hook your apex locator to the file in the MB2. If it's touching metal to metal, it will read that it's patent.
Right, because it's going to complete that circuit.
Yep.
Awesome. Yeah.
Yeah. So do that next time when you get stuck.
When I get down it.
or if you don't, just try that. Sometimes they join, and that's where I end my instrumentation and just operate to there.
Yeah. We're about to get kicked off, so I'm just going to end the live, upload it, and then we'll rejoin and we'll just answer a few questions, have a little chat, and then when people get bored or we get bored, we'll hit end on it.
Yeah, man, I'm here. Yeah, let's reboot this.
Cool.